So, very good evening, one and all. Very good evening, fellow doctors, ladies and gentlemen, here in India. Uh, we thank you all for logging in for this very wonderful academic program and an academic feast that is to follow on the role of vascular ultrasound in cardiovascular disease. As we hear from the experts, the best in the world. As we all know, as clinicians here in India, we tend to develop cardiovascular disease at least a decade much earlier than that of our Caucasian brethren. We tend to have a clustering of risk factors, be it with respect to diabetes, with respect to hypertension, visceral obesity, atherogenic dyslipidemia, so on and so forth. Uh, to know more, uh, or are we doing right with our patients? Are there any ways in which we can properly detect aspects to CAD, or what are the kind of patients, how you would want to stent them? Are there any other ways to understand difficult vessels? Wherein comes the role of vascular ultrasound? To throw more light on the same, we have the best in the world who can educate us on the same. I have the honor of inviting our esteemed faculty for the day. So here is the agenda for you all to see. And I first have the honor of inviting Dr. Christiana Vitali, ma'am, who is a consultant cardiologist at St. George University Hospital, London, and the founding member of ABC Vascular. We also have Dr. Fabrizio Dabate, who's accredited clinical vascular scientist and co-founder and director at ABC Vascular Limited. He's also the co-founder and lead clinical vascular scientist at UK Vein Clinic Limited. Last but not the least, we would also have Professor Giuseppe Rosano joining us soon, who's the president of the HFA at the ESC and professor of cardiology at St. George's University Medical School, London. On the same note, I have the honor of handing over the session to Dr. Christiana Vitali. Ma'am, over to you.
Thank you so much, Dr. Partazarti. Thank you for the lovely introduction. I will share immediately my screen so I can start sharing with you my slide. So my talk will be about the usefulness of vascular ultrasound in stratifying the risk of patients with cardiovascular risk factors. You know better than me that cardiovascular disease are the main cause of morbidity and mortality, and this despite all the improvement in prevention, diagnosis, and treatment. So as Dr. Partazarti mentioned, we have to find a way to better understand those patients that will develop cardiovascular disease. We know that traditional risk factors such as smoking, age, diabetes, and so on are related to the occurrence of negative events at the level of the heart, brain, and peripheral arteries. And we know that this is due to the development of the atherosclerotic process that before becoming evident, develop slowly and silently So the key and our effort is to try to identify those patients that have already atherosclerosis but not yet symptoms. For this reason, several clinical charts have been developed to try to identify the risk of the patients, so to stratify according different classification in low, intermediate, and high risk our patient. Of course, all of us knows the Framingham risk score, the score that has been developed in a new version, taking into consideration also the age of patients, the atherosclerotic cardiovascular risk, and the WHO risk that has tried to stratify the risk even according to different countries. However, these charts give us an idea of the risk based on population assessment. This means that, unfortunately, quite often we fail to identify those patients that will develop cardiovascular disease. As you can see, only 40% of the events happen in those patients that we have identified at high risk. The remaining part, that is the major part, unfortunately, happen in those patients that we have classified at a low or intermediate risk. Why this happen? Maybe can be because we have considered in these charts just a few or the traditional risk factors, so we miss some risk factors, and this is a list of non-traditional risk factors. Dr. Parthasarthi already mentioned metabolic syndrome or other risk factors like early menopause, depression, or something that can interest for us as a doctor is the type of diet. So the social business eating, for example, eating outside, junk food or drinks, this can be associated with a higher risk of cardiovascular disease. Or, as already mentioned, even the clustering of risk factors, because we know that risk factors tend to happen all together. And the risk associated with the risk factor in cluster is higher than the sum of the single risk factors. For this reason, we should try to identify something that helps us to better understand and to better stratify our patient. And the identification of subclinical atherosclerosis is a key factor in better predict the risk in our patients. And I really love to mention this sentence from the editor-in-chief of atherosclerosis: the best test to predict the risk of atherosclerosis is actually to demonstrate the presence of atherosclerosis in the arteries of our patients. Different tools have been used to try to identify early identification of patients with the subclinical atherosclerosis. I'm sure all of you are aware about endothelial function that often happen before, of course, the occurrence of negative events. We have different way to assess endothelial function through the administration of acetylcholine, through the assessment of the brachial arteries, through ultrasound, or even through new methods like this plethysmographic method, the endopath. Another method can be the assessment of arterial stiffness. So we study the rigidity of the aorta, the main vessel, and we study how fast the traveling of the pulse wave travels from carotid to femoral arteries, or the augmentation index that use a tonometer. These methods, however, are used mainly in clinical practice, and arterial stiffness is more related to the risk factor of high level of blood pressure. We can use also the ankle brachial index, so we go and we measure the blood pressure at the level of the peripheral artery. Fabrizio D'Abate will explain better how to perform the ankle brachial index, and we compare the pressure at the level of the distal arteries to the one recorded at the level of the brachial artery. Of course, this method is useful, but however, I would say has a low sensitivity and becomes to be significant in patients usually older than 65 years. We have also the calcium score that you know, of course, very well, but this has the limit that, of course, has to use radiation, and this, of course, limit the repeatability of this test in our patient. So if we consider all these tests, we should say that these are good tests, and several studies have related the endothelial dysfunction, arterial stiffness, and the calcium score with, of course, the occurrence of cardiovascular disease. But we can say that these are surrogate markers of atherosclerosis. Compared to this method, instead, vascular ultrasound permits us to see inside the arteries of our patient and see directly atherosclerosis. You can see here 3 different stages of atherosclerotic disease. In the first image, we can see the measurement, manual measurement of intima media thickness. And again, Fabrizio will better explain this. Here you can see different stages of atherosclerosis. In the image in the middle, you can see a very small plaque that is completely different from the plaque on this, probably the left of the screen, that is a complicated plaque. So as you can see, we can directly understand the different level of atherosclerosis in the arteries of our patients. And several studies have shown that, of course, as atherosclerosis is a systemic disease, what happens in an arteries usually happen in other arteries. This is not 100% sure, but often is quite reliable. So why is useful vascular ultrasound? As I mentioned, we can directly visualize atherosclerosis. We have very accessible arteries, carotid arteries, femoral arteries, and we have not to forget abdominal arteries and the iliac arteries, the peripheral arteries. We can detect the disease in a very good way, so it's very sensitive and very specific. And of course, it is usable in clinical practice. It's cheap, is safe for patients, is not invasive, and we can even repeat the ultrasound scan so we can monitor the disease in our patients. So if we treat our patient and we'll see with some medication, we can follow and we can see if the disease, I wouldn't say if we have a regression, but if we have stability of the disease, of course, if we have progression of the disease. I will show you also another very useful use of vascular ultrasound to implement the compliance of our patient. I think that one of the problems with vascular ultrasound has been that for so many years, we have focused our attention on intima media thickness. So we thought that intima media thickness was a great surrogate marker of atherosclerosis, but now we know that this is not really true. And several meta-analyses have shown this. We know that intima media thickness can be good for assessment in a population study, is related to vascular aging, but for sure, and I really love this title, the intima media thickness is less useful than the presence of plaque. So if we identify atherosclerotic plaques in our artery, the prediction of risk factors and the prediction of the occurrence of disease is much higher compared to intima media thickness. When we perform an assessment of carotid or atherosclerotic plaques, we shouldn't focus our attention just to say the plaque is present or not. This, of course, is the burden of the disease. So if we assess different level of the arteries, we can understand how the disease is spread. We can take some measurement that will be helpful, of course, to monitor the disease. But several studies have also shown that there are some morphological ultrasound features, so some characteristics of the plaques that can be related to the histopathology of the plaques. So we know that those plaques that we define soft, so hypoechoic or anechoic plaques, and I'll show you to better understand, are related to higher risk. This is just one of the several meta-analyses available that tell us that the presence of plaque, of course, is more reliable than the assessment of intima media thickness. So we can say that vascular ultrasound can be a sort of bridge between primary prevention and secondary prevention. And according to this idea, we should redefine the concept of screening or our patient for asymptomatic disease. When we think about carotid arteries, I'm sure all of you think one patient that had probably cerebrovascular symptoms or TIA, and we checked those patients to understand if as a carotid plaque that has to be treated with stenting or endarterectomy compared to a plaque that can be treated with best medical treatment because the dimension and the degree of stenosis is less than 69%. However, if we change our approach and if we think at vascular ultrasound in a way to detect subclinical atherosclerosis, we can understand that we can use this tool to verify the presence of atherosclerosis. And if we find atherosclerosis, this gives us the chance to better stratify our patients. If we better stratify our patient, we can better treat our patients. So we can individualize the treatment, because as I mentioned, we are of course interested about population, but we want to treat as best as we can the patient that we have in front of us. And this is a very nice study where if we use carotid ultrasound, as you can see, we can better reclassify all these patients. This means that all these patients that I've highlighted here identify according the risk, the chart of risk score, as patient with low risk can be moved and become a patient at intermediate risk, or I would say directly to high risk, and we will see this. And this patient to intermediate risk or high risk directly to a very high risk. So we will be able to better reclassify 46% of patients. So how we can use the assessment of subclinical atherosclerosis in this very simple flowchart? You can see if we have a low risk patient, maybe we are not really sure this is a true low risk patient, we can perform the assessment. Here was presented all the methods and the tools that I've shown you, or directly vascular ultrasound. And if we find something wrong, if we find the subclinical atherosclerosis, of course, we can reclassify our patient to a high risk, while if the patient has no any changes, this means that is a real patient at low risk. So I really like to say that ultrasound is a window because give us the chance to look inside the arteries of our patients. And as I mentioned earlier, and as the guideline tell us, ultrasound can be used to detect subclinical arteriosclerosis, but also to assess the plaque morphology to better stratify and predict the occurrence of events. And as is mentioned in the latest guideline of the ESVS, if we look at the progression of the disease in particular, both if we are treating or not treating our patients, sometimes we are uncertain, so we do not prescribe a medication, and after the follow-up, we can see that there is a progression of the disease. This is definitely the indication that we have to start medication. Opposite, if we start the medication, we have no disease progression of the disease, we know that we are on the right side. Of course, plaque lucency, as it was mentioned, is another parameter. Not often used because it's not well standardized. So there is lots of discussion how to classify the echogenicity of the plaque. But I think that all of you can really see that these two plaques, this is a plaque at the level of the posterior wall of the carotid, the bulb of the carotid bulb. This instead this homogeneous plaque at the level of the anterior wall of the carotid arteries. As you can see, these plaques are for sure different. So they show different morphological features. And while this plaque, the one at the posterior wall, is defined hyperechoic, and usually we say this is a stable plaque because it has plenty of calcium and less cholesterol. This plaque on the opposite wall instead is, I would say, a dangerous plaque. So as you can see in this graph, echolucent plaque are associated, of course, with this is shown opposite way, associated with a higher risk of events, not only cerebrovascular events, but also coronary events. And as you can see on the left, if we have a patient with stable coronary artery disease with echolucent plaque, we have an increased risk. So all the international guidelines, and I'm sorry if I'm presenting the one of the European Society of Cardiology, the one of arterial hypertension, cardiovascular prevention, diabetes, and dyslipidemia, have shown that plaques are better indicator of compared to intima media thickness of the real cardiovascular risk of our patients, and they give us the chance to better reclassify our patient. At the moment, only the one on diabetes discuss about the morphological feature of atherosclerotic plaque. So we can use vascular ultrasound as a risk modifier to better identify our patients. When we discuss about vascular ultrasound, usually we discuss and we think about carotid arteries, even because these are more related to cerebrovascular events, and we often forget peripheral arterial disease. If you remember, the American Association asked for take off your socks, so a campaign just to improve sensibilization on peripheral arterial disease. And I would say we shouldn't forget abdominal aorta. Abdominal aorta often is more associated, or I would say can be associated with atherosclerosis. Often we can see even on X-ray of our patient the presence of calcium at the level of the abdominal aorta. However, in our patient, and in particular in the patients that are cardiological patients, so with many risk factors, and in particular in smokers, or in patients that have a familiarity for aneurysm, we should look for the presence of an aneurysm. We know that if we have a rupture of the aneurysm, probably we lost the patient. If we do prevention screening the abdominal aorta, and both Fabrizio and Professor Rosano will show that is an easy assessment at the end even of the transthoracic echocardio, we can save several lives. So it's not just carotid arteries, I was saying, is also femoral arteries. These are two similar studies that have tried to understand the occurrence and the progression of subclinical atherosclerosis. As you can see, the patients enrolled were quite young patients. In the Aragon Workers' Health Study, only men were enrolled, compared the PESA study, in which both women and men have been enrolled, even if women were less compared the men enrolled. If we see what the study found, is that subclinical atherosclerosis was present in roughly 62% of middle-aged subjects, usually subjects that are low intermediate risk, and are those subjects that will develop often cardiovascular disease. So you can understand how important is looking for the presence of atherosclerosis. And I would say not only at the level of the carotid arteries, but also at the level of the other districts that I've already mentioned. If we see the prevalence of the disease according to different location, you see that we have similar results compared the two studies when, of course, we look at men. You can see that men have a higher prevalence of subclinical atherosclerosis, but I would like to put your attention on the fact that the women enrolled, of course, were quite young, so probably in an age premenopausal. And as you know, cardiovascular disease are the main cause of death, but after menopause. This means that we have to be very careful after menopause, but as you can see even before, because it's not true that women are completely protected by the level of hormones against atherosclerosis. If we look at the presence of subclinical atherosclerosis, and as you can see, a different stage of atherosclerosis. So if one site is involved in black, if 2 or 3 sites are involved in red, or if we have a generalized involvement, you can see that 40% of patients at low risk have disease, 60% of those intermediate risk, and of course a higher percentage in those patients that we already know that are high risk. And of course, in the Aragon study, we had similar results. Again, just to put your attention how important is to perform an early assessment in those, of course, patients that have cardiovascular risk factor and more than one cardiovascular risk factors, or where we are unsure if they are low intermediate risk. As you can see, even in those without cardiovascular risk factor, we can have the presence of atherosclerosis at the level of the carotid arteries, femoral arteries, and coronary arteries. So if we consider vascular ultrasound, as I mentioned as a bridge, you can see how useful, and I hope you agree with me, how useful can be ultrasound in better screen patients in primary prevention and maybe better treat these patients. All of you know that cholesterol is one of the main cardiovascular risk factors related to atherosclerosis. And as you can clearly see, the higher the level of cholesterol, of course, the higher is the presence of the disease. All of you know, and all of us have to use threshold cutoff because we need to try to standardize our treatment, but we know that cholesterol is a continuum. So all throughout the level of cholesterol, we are associated with risk of atherosclerosis. And you know that now all the guidelines mention that the lower, the better. And as you can see, this seems that is definitely true, because if we have very low level, around 50-60 milligram deciliter of LDL, we cannot find disease in, remember, this young population. This means that if we start treating cholesterol very early, probably we have less progression of the disease, atherosclerotic disease. So our treatment has to be individualized. So if we better understand the risk in our patient, we will know when to start treatment. And of course, statins and PCSK9 inhibitors are very useful drug. There are so many papers that have demonstrated that statin and some papers on PCSK9 inhibitors too, that they can stabilize the plaques or even reduce or at least avoid their progression. I would say when I perform an ultrasound scan, is very clear that when I have a patient with very high level of cholesterol, sometimes you have that feature of the plaque, of the soft plaque, so the apocoic plaque, that is, just to understand, is light gray or black compared to the stable plaque that are white, so calcified. So often happen when we start a lipid lowering therapy, the plaque becomes more defined. So for this, sometimes we think that there is a regression. I would say there is stabilization of the plaque at the level of the wall. So as you can see, if we look at different districts of arteries, if we do a sort of a SPLURI assessment, and in particular, if we assess carotid artery, very easily, carotid arteries, femoral arteries, and abdominal arteries, we can better understand the burden of the disease in our patient. Of course, is not needed to perform a very detailed ultrasound scan, if we can identify something, we can refer the patient to the specialist. But if you have a patient, as I already mentioned, where you are unsure, if we look at the carotid and femoral artery, you can easily understand if there is already atherosclerosis or not. And this can be even helpful to do a first screening of the patient that maybe we have to refer to do a complete and a deep ultrasound scan. I mentioned at the beginning that ultrasound, vascular ultrasound, can also improve adherence of our patient, and this is a beautiful study. So patients with between 40 and 60 years old have been enrolled, and both clinicians and patients have been divided in two different groups. One was the interventional group and the other one was the control group. So the interventional groups was exposed to an image of the atherosclerosis. Both the doctor and patients were exposed to the image of the patient so they can visualize the presence of atherosclerosis where present. And this was associated with a higher compliance of patient in taking the prescription, in a higher percentage of doctor prescribing lipid lowering, and of course in a reduction of the score of our patients. So to conclude, I think that the main messages are subclinical atherosclerotic plaques are very common, even though in patients at low moderate risk. We have seen even at this, we can find even 62% of patients with atherosclerosis. The detection of subclinical atherosclerosis at the level of peripheral arteries, carotid and femoral arteries. I didn't mention abdominal aorta because I mentioned that is more associated with abdominal aneurysm, but we know that the risk factors are the same. They can improve the risk prediction of our patient, reclassify our patient, and reclassify in both directions. So at a higher risk or a lower risk if atherosclerosis is not present, and they are more sensible than the conventional risk factors. We have just seen that the subclinical atherosclerosis can improve adherence of our patients, so we can better help our patient to follow our indication. And we shouldn't forget that the vascular ultrasound has so many advantages because it's very well available worldwide. To perform a vascular ultrasound is a very low-cost exam, is safe, is non-invasive for our patient, doesn't use radiation compare other tools, but of course is operator dependent. Thank you for the attention.
Thank you so much, ma'am, for those wonderful, clean, clear, crisp messages for the audience, be it on carotid ultrasound or femoral or abdominal. We now hand over the session to Professor Fabrizio Diabate, Professor Fabrizio Diabate, for his session on the session.
I'm not professor, thanks.
Yes, sir.
We got one professor, and that's Rossano. So thank you very much. I think Christiana answered a lot of questions on why doctors should do ultrasound. And, oops, sorry, just let me reduce this. In this talk today, I just want to show you what is the use of vascular ultrasound for the detection of atherosclerotic disease at different levels, which are the ones that Dr. Vitale has mentioned. So carotid arteries, peripheral arteries, and abdominal aneurysm. So the first thing I'd like to share with you is how important it is for doctors to know about ultrasound. Vascular ultrasound and other application of ultrasound is becoming the new stethoscope for doctors. In particular, vascular ultrasound is a first tool used in the diagnostic journey of patient, as Dr. Vitale has highlighted. This can help for screening, diagnosis, follow-up, and even to monitor the progression of conditions like carotid plaques and response to treatment. There is growing evidence that doctors should learn vascular ultrasound and other application of ultrasound, and some universities are making mandatory ultrasound for different specialty during the medical school. This will equip doctors with an additional tool to use for better stratifying and managing cardiovascular risk in patients. So I encourage all doctors to familiarize with ultrasound, and in particular with vascular ultrasound. So in this talk today, we're going to see carotid arteries, peripheral arteries, and aneurysm. As per the carotid arteries, ultrasound can determine patency of blood vessel, subclinical atherosclerosis, as Dr. Vitale mentioned, presence of plaques, plaque features, and what is the hemodynamic impact of plaques on blood flow. When we study carotid arteries, but any artery, for those that are not familiar with ultrasound, we use three different modes. One is called B mode, when we can study the anatomy and any alteration of the arterial wall. On B mode, I just want to draw your attention on this artery. It's a normal carotid artery. On B mode, the carotid arteries appear as an anechoic structure, which means black, with some intima media complex, which is the ones Dr. Vitale mentioned, which appears with shades of gray. So this is a normal artery without any abnormality of the wall and with black lumen. If there is a plaque, we can see that this protrudes from the intima media up into the lumen. So this is indicative of the presence of arterial wall abnormalities. Therefore, there is presence of atherosclerosis. The next method is called color flow. Color flow will study the blood dynamic and will tell you where blood is and whether there is any filling defect or whether there is any turbulent flow. In presence of a normal artery, the blood flow will appear with color filling the entire lumen of the artery, and you can appreciate the pulsatility of the artery. In presence of a plaque, we can often see a stenosis, which is the narrowing caused by the artery. This can be detected with the presence of turbulent flow, which is represented by the presence of color flow aliasing, which is this mosaic of colors that you can see on this video. Finally, we can measure the speed of the blood within the carotid arteries and other arteries. We generally measure the peak systolic velocity, and this velocity must be below 125 centimeters per second to indicate the presence of a normal flow. As you can see in the previous case that I have illustrated you, there is a severe stenosis, as the peak systolic velocity are 500 centimeters per second. So this is indicative of a severe narrowing of the artery. But let's see what are the beauty of ultrasound is that you can follow a patient from the stage of normal artery, where there is no irregularity, to early stage of atherosclerosis, subclinical atherosclerosis, where you can see some focal initial thickening, to the development of plaques, and to the point where such plaque can complicate with an ulceration, as in this case, and eventually, in the very worst case scenario, rupture and cause a thrombosis of the artery with, as we know, devastating consequences like stroke. As Dr. Vitale already mentioned, the intima media thickening is a double line between on the posterior wall and anterior wall of the common carotid artery. You measure basically the maximum heights of these two lines, which appear with different shades of echogenicity on ultrasound, and the value must be less than 0.9. But as Dr. Vitale has already highlighted, the presence of a carotid plaque has a higher diagnostic accuracy for prediction of future myocardial infarction and other cardiovascular events. So the transition between a normal intima media complex to plaque is not that set, but generally we use a cutoff value of 1.5 millimeter to define the presence of a plaque or the presence of doubling the size of a normal intima media thickening. Once you identify plaques, which appear mostly on B mode as protrusion from the wall of the artery, we can use ultrasound to discriminate between those plaques that are more likely to be linked to symptoms to those that are considered stable. How do we do this? There are two different approaches. One is to study the hemodynamic impact, so measuring the grade of stenosis, which has been used for many, many years as the only criteria for severity of plaques. But now we know that this is not the only parameter. We have to study the morphology of the plaque. So the morphology is studied with ultrasound with different criteria, which I'll show you now. As I mentioned earlier, the presence of a stenosis is detected with color flow aliasing and presence of significant increase of peak systolic velocity. When we find the plaque, the first thing we need to do is to detect the location of the plaque. Most plaques are located at the level of the carotid bifurcation, as this is a region of flow divider and prone to turbulences. So we can see here different ultrasound images of carotid plaques at different levels throughout the carotid arteries. Another important parameter is the geometry. Plaques can affect the entire segments of a vessel with a central lumen. These are defined concentric, or eccentric plaques with the growth of the plaque eccentrically and only leaving the lumen marginally in only one side of the artery. These plaques are more prone to increase the incidence of ipsilateral cerebrovascular events. This is a clear example of two eccentric plaques. This is a longitudinal view. We can see the plaque at the level of the carotid bulb here. This is the cross-sectional view. You can see only the patent lumen on one side. And this is a very large plaque that we found in a patient with an acute ischemic stroke affecting the middle cerebral artery. It's an eccentric plaque and is leaving just very small patent lumen. The key of all parameters when you assess carotid plaque is the echogenicity. The echogenicity is the ability of any structure in our body to reflect ultrasound waves. The higher is the reflection, the higher is the plaque. So to just simplify, we can have white plaques to black plaques. So white is a higher echogenicity, black means is low reflection. The risk increases with the presence of low echogenicity. So anechoic plaques are the ones that are most linked to increased risk, as Christiana explained. So echogenicity is the main ultrasound parameter. Hypoanechoic plaques are the ones mostly related to higher risk. And there is a particular type of plaque, which is the echolucent plaque, where plaques appear black. These are basically the ones that we need to pay most attention for a better medical approach. How do we assess echogenicity? We can assess echogenicity either visually or with offline assessment. The most normal approach is the visual assessment. However, we use this because it's more rapid. The offline assessment requires an offline software, but it's very time consuming and is used mostly for research. This is a clear example of a hyperechoic plaque, and this is a plaque with low echogenicity, which is actually obstructing the entire lumen of the internal carotid artery. This is another example of those plaques that Dr. Vitale mentioned that we need to be careful when we find them. We can all see that there is evidence of an anechoic region of this plaque. So this plaque most likely has a high lipid content and therefore requires further attention and eventually further investigation with ultrasound. As you all know, plaques have different features that can make the plaque vulnerable. These features are the presence of a lipid necrotic core, the presence of thrombus, the presence of intraplaque hemorrhage, and the presence of neovessel, and the presence of ulceration of the surface. Ultrasound is really good in detecting plaque ulceration. However, it cannot distinguish between the presence of thrombus, lipid necrotic core, and intraplaque hemorrhage, as they all appear black. So to be practical, in the plaque that Dr. Vitale showed you, the anechoic region here could be either lipid or intraplaque hemorrhage. One thing is sure, this plaque is dangerous and therefore will increase the risk of the patient, and you need to take action on this type of plaques. Furthermore, the echogenicity can be homogeneously distributed across the plaque or heterogeneously distributed. The heterogeneous plaques are the ones that increase the risk of stroke more than the homogeneous. Just to give an example, we can see that this is all hyperechoic, so it's a homogeneous plaque. These ones are hyperechoic plaque with acoustic shadowing, so there's a very high reflective structure, so we don't know exactly what's going on underneath here. So these plaques are defined calcified and are difficult to classify. For the calcification on carotid plaques, there is still debate on whether these have a protective effect or not. The plaque surface, it's something that we can clearly assess with ultrasound, and plaques with regular surface are the ones with lower risk. There might be depressions within the surface of plaques, and when these depressions are deeper than 2 millimeters, this is a criteria that we use to define the plaque as ulcerated. So this plaque is definitely more dangerous than this plaque over here, as there is presence of an ulceration, which is a clear major risk factor for cerebrovascular events. Just to show you another example, we can see here irregularity of the plaques, whether these ones present a surface that is very regular. And just to give you an example of what an ulceration looks like on ultrasound, this is a transverse view of the carotid bulb. We have a plaque here with this anechoic region over here. This region is an ulceration, which presents a depth of 3.8 millimeter. You can use a longitudinal view as well, and you can see the ulceration. And by using color flow, you can see blood going into this ulceration. So again, this is a dangerous plaque. So the take-home message for carotid plaques is that carotid stenosis is not the only parameter that you should use. Focus on surface, focus on the echogenicity, focus on the distribution of echogenicity, as these are all parameters that will increase the risk of your patients, and you can use these parameters to better stratify the risk and manage your patients. Ultrasound, as Dr. Vitale mentioned, can be used in peripheral arteries, where you can find stenosis and blockages, but also aneurysm. To detect stenosis and obstruction, we can use encobrachial pressure index. You measure the blood pressure with a Doppler, a pulse wave Doppler at the level of the brachial artery and at the level of the tibial arteries. You divide the tibial artery pressure by the brachial artery, and this value should be above 0.9, or actually should be 1. And then we can use ultrasound. The encobrachial pressure index can be measured even with ultrasound, although it's a little bit more complex than using a pulse wave Doppler. And it is considered as an independent indicator for the risk of atherothrombotic events in other vascular beds. A very high encobrachial pressure index represents arterial stiffening and increase the risk of cardiovascular events. However, such method is not very sensitive in patients with diabetes and chronic kidney disease, as the arteries presents a high calcification. As per the carotid artery, for the peripheral arteries, we do use a combination of B mode, color flow, and pulse wave Doppler. The pulse wave Doppler is more complex, as the waveforms are considered triphasic, so you have 3 phases. And this is because these arteries presents a high resistance. When the shape of the Doppler waveform changes and you can see only one phase, that means that there is disease. Doing a peripheral arterial disease is a very time-consuming procedure. It requires a specialist, but any doctor with competencies in ultrasound can do a fast ultrasound by assessing the common femoral artery, which normally appears as an anechoic structure with a normal wall without any protruding material. And then you can measure, also you can assess the popliteal artery and the distal artery at the level of the tibial artery. This will give you a clear indication on whether your patients may require a full assessment of the peripheral arteries. So at the level of the femoral artery, the plaques are not like the carotid artery where they're more focalized. Plaques within the femoral artery, they are basically diffusely distributed and they affect most of the wall. In this case, we have a cauliflower with a funny like this carotid plaque, which is very calcified. So the presence of this plaque at the level of a femoral artery will definitely change the risk stratification of your patients. Again, we use color flow to identify aliasing and pulse wave Doppler to measure the peak systolic velocity, which is increased in presence of a stenosis. I just want to show you an example of a patient that was screened by a cardiologist.
Femoral artery,
Sorry, it was just,
where there is
and you can see the presence of a plaque here, which has rupture, and there is hypoechoic material within the lumen. So this is a thrombus. So the patient presented with acute pain in the lower limbs on the right side. And if you apply color, there is no flow, so you don't see any color. So that means that there is an occlusion. And ultimately, when you measure the pulse wave Doppler at the level of the foot, you have monophasic flow, which is, as I mentioned earlier, indicative of the presence of obstruction in this region. So another pathology that you can encounter is the presence of aneurysm in the peripheral arteries, which are defined as doubling the size of a normal artery. Popliteal arteries are the ones that are most common to find, but you can find aneurysm at the level of the common femoral artery as well. Just to give an example, an aneurysm appears as a large circle on your screen, and in this case, it's a very large aneurysm of the popliteal artery. This is the longitudinal view. You have a thrombus within the aneurysm. This is the normal artery size. You can see it's way bigger than the double of that one. And this is the longitudinal view. The anechoic region is the patent lumen of the artery. So this patient definitely requires urgent attention, as there is a very large aneurysm. And when they have such a huge amount of thrombus, this can cause embolization within the tibial artery. When do you perform the popliteal artery assessment? You need to perform, and you find an aneurysm. It's highly suggested to scan the aorta, as patients with the popliteal artery aneurysm, they are more likely to have an abdominal aortic aneurysm. When can you do this? If you're a cardiologist, at the end of your transthoracic assessment, you can perform an assessment of the abdominal aorta. You can use a phased array, or you can use a curvilinear probe. As I mentioned earlier, the aneurysm will appear as an enlargement, as a circle of the aorta. And what we do, we measure the maximum diameter from the anterior wall to the posterior wall. Using ultrasound, the abdominal aorta will appear as a circle in B mode and a tube in longitudinal view. This is by using the convex probe, and this is by using the phased array probe, which cardiologists use. When you measure the maximum antero-posterior diameter, you will get a size of the aorta. If this size is below 2.5 centimeter, this is considered a normal aorta. If this size is between 2.5 and 3 centimeter, the aorta is defined ectatic. So it's already expanding. It's not normal. It's potentially may progress to develop an aneurysm. We define an aneurysm when the anteroposterior diameter is 3 centimeter. So the diameter is the diameter that goes from here, anterior wall of the aorta, to the posterior wall of the aorta. This is a patient that was screened by a cardiologist at the end of a transthoracic echocardiogram. The cardiologist had a convex probe, therefore the images appears a bit different from the phased array. What you can see here is a very large fusiform infrarenal abdominal aortic aneurysm with the presence of a thrombus, which is occupying most of the lumen. You can see patent residual lumen here. And when we measure the maximum antero-posterior diameter, this is giving a size of 5.5 centimeter, which is a surgical threshold used by most vascular surgeons to intervene on such patient. In this case, the cardiologist saved this patient's life, as the patient was eligible for endovascular repair. And today, this patient is still with us, is coming for follow-up, and we are very happy. So cardiologists, doctors who practice vascular ultrasound can really use such tool to improve the management of patients, to better stratifying the cardiovascular risk, and therefore to optimize outcome and management of patients. Thanks for your attention. I think you muted, Dr. Paris. You are muted.
Thank you so much, Fabrizio. It was wonderful to hear from you, and we are very sure the audience has learned from the same. I believe Professor Rosano is yet to join us. So in the interim...
Yes, so sorry, I may say something before the talk of Professor Rosano. Sure. Just to highlight again, maybe thank you, Fabrizio, with this very, very comprehensive overview, I would say, of vascular ultrasound. I hope that the doctors have appreciated all the images, and I hope that we have transmitted, of course, what all the information that vascular ultrasound can give to doctors. I would say that I would try, if you give me just a few minutes, to try to highlight the importance or maybe what doctors can do if they are not very familiar with the vascular ultrasound, because of course Fabrizio showed us the different modes: B mode, color Doppler, pulse wave Doppler. Of course, these are the three main modes for a complete vascular assessment of the arteries, but not necessarily, or there are different, of course, stages when we perform a vascular ultrasound. I remember when I started, of course, you start looking at the B mode and you start to try to identify plaques to understand the difference, first to understand what it means and how appear a normal vessel compare, of course, a disease vessel. So, of course, there is a very long learning curves, and for this reason, ultrasound is an operator-dependent tool. So it's not easy to perform since the beginning. Of course, cardiologists has very good knowledge to easily understand and easily learn. And for this, we think and we wanted to share with cardiologists, of course, the utility of vascular ultrasound. But I want to say maybe we can think about the use of vascular ultrasound at different levels. So the first level can be a screening examination. I don't know if Fabrizio is, of course, agree with my point of view, and eventually...
I wanted to add something, Christiana. You said something in your talk there, I think for doctors should be really inspiring. I think ultrasound can be used at different levels. So you don't need to be a specialist to see that there is a plaque or that there is an aneurysm. The case I showed from the abdominal aorta, that was a case from a cardiologist that wasn't an expert in vascular ultrasound. But when you put a probe on a patient abdomen and you see a large round-shaped structure, you definitely can make such a huge impact on that patient's life. And, you know, that patient, thanks to that cardiologist that went the extra mile to assess the aorta, today is with us. Because if you optimize, patients come for hypertension, you do echocardiogram to see whether there is any alteration of the structure of the heart, but then you don't look further, you focus on the heart, but then the patient dies for a rupture of abdominal aortic aneurysm. So I think ultrasound, I'm a great fan of giving ultrasound to everyone. I think at different levels. And if you find disease, then you say, okay, this patient require a full assessment. Then you pass it on to a specialist like us, that we do this for living. We are specialists in vascular ultrasound. So we see blood vessels all day long. So we would find any disease that you're concerned about.
Exactly. So, yeah. Indeed, what I just to try to summarize and to give some simple key messages. So I would say if you just use your probes and even a curvilinear, maybe is not the best probes, but often we have a machine that, of course, have the linear probe that we usually use for the peripheral arteries. Please give a look at the arteries of your patient. First of all, they really love it, because they think, they have the feeling that you are taking care of them in a comprehensive way. So if you look at the carotid and if you extend even to the femoral artery, I think femoral artery is a new concept, because usually when cardiologists have assessed mainly carotid artery and had a look at the carotid arteries, please maybe ask your patient even to pull down the trousers and show the femoral arteries. Better if we can have a look also to the abdominal aorta, but going by step, I would say we need just to understand first if patient has a plaque or not. So this is the screening exam. So you don't need probably particular expertise. With Vascular and with our courses on ABC, we have tried to give some basic knowledges, but full knowledges to perform an ultrasound scan. So we try to give information step by step, just to understand what it means a normal arteries and what it means a disease artery. So this is the first step. So understand if your patients have something wrong, have something in the arteries or not. This is the first, I would say, answer that we should give at our examination, in particular when some cardiologist that is not trained in vascular ultrasound can do. So first answer, yes plaque, no plaque, and this give us the information how to treat our patients, because we already mentioned if there is a plaque, this means immediately presence of the disease, so immediately high risk of that patient. So we need to improve and individualize the treatment. Of course, I would say later on when we will become more familiar with the vascular ultrasound, and at the end is a learning curve. So you will become familiar with the different aspects. You will definitely understand if a plaque is soft. So as Fabrizio showed, is dark, is black, is light gray. This is a dangerous plaque, in particular if the surface is not regular. So if we go to the next step, and if we think, okay, how looks this plaque, we can think to two main aspects. We don't need to be a very specialist that has performed so many exams, but if we see a plaque that appears echolucent, so anechoic, so black or light gray, this means that probably that plaque has a high content of cholesterol. If has high content of cholesterol, probably that patient has to be treated more carefully, even though we have already started our treatment, our lipid lowering treatment. These plaques are more dangerous because tend to progress. This means they tend to become bigger, to occupy mostly the lumen. Often my patient, when I perform an exam, the first thing that I'll ask me, how big is the plaque? This is unfortunately what some technicians have transmitted to the patient, is not a number. We are not really interested to the number, and please avoid to say your patient, you have a plaque that is 23% deep or is 44, because they remember just that number. And if they find another operator that just tell them the plaque is not 44, it's 46, they panic, because they think that something wrong is happening, that the disease is progressing, even if they are taking the medications. So we should try to avoid to share even with the patients the number, or to explain to them. Numbers are for us, for doctors to speak the same languages, to communicate better. We need to standardize. As for cholesterol, we need numbers, unfortunately, but we don't like numbers. We like the patients. We want to treat the patients, not the numbers. So when we speak with our patient, we share the results even of an exam. I would say the most important message to share is, look, you have cardiovascular risk factors. You don't want to intake the medication that I'm suggesting you, but please look at your artery. You have some plaque. If you have this plaque here at the level of the carotid arteries, probably you will have plaques at the level of the heart. But I cannot perform an assessment of your heart without doing something more invasive. So please trust me, the disease is a systemic disease. This means that what you have at the level of the carotid arteries probably is already spread. We don't want to panic the patients, of course. We have not to terrorize the patients. But we want to tell them, please, and try to give you some medication, because I have the knowledge and I have data that show that if I'm giving you this medication, and in particular the lipid lowering medication, your plaque, we are doing our best to stabilize the plaque. We cannot cancel what you already have. The damage is already there. But if we are doing our best, we will be probably able to stabilize the plaque.
And
This means that
Dr. Vitali, Dr. Vitali and Dr. Fabrizio, if I might just ask, some very wonderful perspectives actually came up in your talk, discussing ultrasound as a screening tool, which is something we probably in India in a resource-crunched setting might not directly implement, but the way you showed it, saying, it would make an impact to the patient. And also those slides where, the patient is on statins or the patient is on PCSK9 inhibitors and the plaque is stabilized, it's more ecogenic. Probably even that empowers the patient in the patient's own journey, involves the patient in his or her journey to continue with medications, ensure compliance. Wonderful, very nice.
That's what I was going to stress, that Christiana said in her presentation. Vascular ultrasound is even a way to communicate and to show, sometimes patients, when you show them on the screen, this is not good. You explain them, it's a tool of communication. And one thing Christiana said is that helps adherence to treatment. So you can really use not only ultrasound to improve the stratification and management, but even communication with patients. And, I think any doctors can really learn the basics, and you can use this daily in your daily practice. And the more you do it, the better you become. And then eventually you want to become a specialist. So even your profession, it's empowered by using it.
Another thing which you both showed in your slides, which actually tickles the interest of a lot of clinicians, would be actually the idea of showing plaques. Not just from the perspective of carotid or femoral. We in India usually tend to have a lesser incidence of peripheral arterial disease, but yes, there is a huge incidence of coronary artery disease and strokes. So my question to both would be, are there any specific locations on the carotid artery where you would possibly say the plaque gets more vulnerable to rupture? For example, at the bifurcation, where you just said there's more shear stress as a result of flow. Any other aspects one needs to remember, especially while doing a carotid ultrasound? Your take on the same, Dr. Vitali and Dr. Fabrizio.
Yeah, I would say definitely, as you mentioned, plaques are often at the level of the carotid bulb, because as you said, that there is the place where we have turbulence, and we know that the shear stress is impaired. And so that point is the clear point that we have to look and focus our attention. However, thank you for mentioning this. We never should forget to look all the vessel. And for this, we do the scan first in transverse view, because in transverse view, we have a clear idea of the vessel. In transverse view, of course, the vessel appears a circle, as Fabrizio mentioned. So this means that we can clearly follow the vessel until the end. Sometimes, unfortunately, we have even disease distally. to the vessel. So we should perform, we try to go as much further as we can to assess all the arteries. This is at the level of the carotid arteries. Of course, at the level of the femoral arteries, again, we have the bifurcation, the femoral bifurcation, where plaques usually are. But I would say at the level of the peripheral arteries, the approach is a bit different. So while in the carotid arteries, we are really focused on looking at the morphology of the plaque, of the extension of the plaques. At the level of the peripheral arteries, we focus our attention on the femoral arteries. So we study the morphology at the level of the bifurcation, but we are really interested to understand if there is an impairment of flow. So this is the main aim. Look at the femoral arteries, maybe look distally, better if we check the 3 places that Fabrizio mentioned, but we should evaluate how flow it is.
Sure, ma'am. Thank you. We have Professor Rosano, who's now joined us for the session. Professor Rosano, welcome.
Hello. Thank you. Thank you. I was just jumping in from another meeting in India.
Sure, Professor. It's an honor to have you. We had some wonderful sessions with Dr. Vitali as well as Dr. Fabrizio, who enlightened the Indian audience on vascular ultrasound. And we would now hand over the session to you before we go to the audience Q&A. Over to you, sir.
First of all, thank you for having me. And it's really a great pleasure. So what I'll do in the next 20 minutes is to discuss on the medical management of polyvascular disease. Now, if you look at this CT scan, this is a CT scan of a mummy and performed at the National Museum of Cairo, where they, with the CT scan, they identified peripheral vascular disease already in 4,000 years ago in mummies. And mummies at that time, they were, the mean age was 32, 34 years. And as you can see, already it was possible to identify calcification at the level of aorta and iliac arteries, as well as the carotid arteries. And here, look, the effect on coronary arteries. So this is to say that coronary artery disease, atherosclerosis, is a process that starts early in life and then progresses, and in some people tends to become unstable. In some other people, then it can stay silent for a long time. But if present, and especially if present in specific places like the aorta, the carotid artery, or in the femoral arteries, that is predictive of future cardiovascular events. So we have the arterial disease, atherosclerosis can be demonstrated at the level, as I said, of the aorta, coronary artery, and peripheral arteries, with different territories, with different presentations. One patient may present with a stroke, another one with a steel subclavian syndrome, another one with a chronic mesenteric ischemia with mesenteric claudication, and others with acute coronary events. And assessing the presence of atherosclerosis at the different levels, it allows us to better identify and characterize this multi-site atherosclerotic disease. And multi-site artery disease is therefore defined as the simultaneous presence of clinically relevant atherosclerotic lesions in at least 2 major vascular territories. So if you look at the mummies that I showed you earlier, they had in 4 territories the disease, but often that can be at the level of the carotid artery and of the coronary arteries, or at the level of the aorta and peripheral arteries. You can use alternatively multi-site or polyvascular. That doesn't make much of a difference. And multi-site disease is usually it's present in 10 to 15% with coronary artery disease, and in 60 to 70% in patients with carotid disease or peripheral femoral artery disease. Now, the presence, why we tend to underestimate the presence of coronary artery disease in patients with peripheral vascular disease is because sometimes, very often, patients are limited by their claudication and they do not reach the threshold for angina or for coronary ischemia. Also, usually 1 in 6 patients with atherosclerotic disease have a multi-site atherosclerotic disease, and therefore it's very important to screen for the asymptomatic disease in additional sites that have not been proven to improve the prognosis. I mean, that is very important because it very much depends what is the disease that is prevalent. If we're going to see a patient with a significant coronary atherosclerosis, so they have to undergo a coronary surgery, and that is especially in emergency. I mean, we will be less interested in knowing about the peripheral disease. But whilst, on the other hand, if we have a patient with carotid atherosclerosis or peripheral atherosclerosis, then it's important to assess the presence of coronary artery disease because that can influence the prognosis. So if we look at the localization of other disease, you can see that in patients with coronary artery disease, we have a ranging between 9 to up to 10% of patients may have a carotid stenosis greater than 70%, 16% may have a peripheral arterial disease or peripheral limb arterial disease, around 16%, and 15% also of the other aroused greater than 75%. On the other way around, we have in patients with carotid stenosis, we have a very high prevalence of coronary artery disease. And it's the same in patients with peripheral arterial disease. Now, what does it tell you? It tells you that if you have a patient with where you detect the carotid atherosclerosis, carotid plaque, or the plaque on the femoral arteries or iliac artery, then these patients are very likely to have coronary artery disease. And therefore, the identification of a disease at the carotid or femoral artery puts those patients or patients with risk factors at very high risk of cardiovascular disease. Now, you may think that there may be differences in the different populations according to the different occurrence or the different statistics that we have. And I digged out some specific data for India and for the Southeast Asia region, where you can see the prevalence of carotid plaque is significantly higher than in the Americas and in Europe. And that is something that is very important because that highlights the importance to identify the carotid artery disease, but also peripheral arterial disease in the Indian population. And that may be related to the increased risk factor for similar BMI in the Southeast Asian population compared to the Caucasian population. But another concept that is very important and for which the ultrasound is also very, very important, and I believe you've discussed already about the plaque morphology, is that it's not the size of the plaque that is important, but what is important is its morphology. Now, if you look at this study, this was a study that assessed the rates of major cardiovascular events according to the degree of coronary stenosis, but also according to the presence of a thin cap fibroatheroma. So you can see that in plaques that were stable, the ones in blue, even more than 70% stenosis did not add anything in terms of future events. The future events were very low. But if there's a thin cap fibroatheroma, then highlighted by this red here, you can see that the risk increases significantly, also for those plaques who are not significant. And this correlates with the morphology of the plaque that I believe you've seen in the previous presentations, where they are irregular, they have a thin cap, and therefore we can extrapolate from the carotid echo the probability of the unstable plaques. Now, of course, there are similarities and differences in atherosclerosis. There are some vessels that are more prone to develop atherosclerosis than others. We know that, for example, the carotid artery has a tendency to develop more disease at the bifurcation, and that is because the flow at the bifurcation is not any longer any parallel flow, but the shear stress increases. Whilst in the lower extremity, we tend to have more fibrosis and calcification. But when you look at the plaques and look at the instability of the plaques, you can see that the same thing that occurs at the coronary arteries occurs at the peripheral vascular level. So you see here these plaques that were in red, where there was an uptake of 18 fluorodeoxyglucose, and identified those plaques that at the ultrasound will show as irregular plaques. So the occlusion of peripheral artery is something that was already identified in the general population. Already in the 60s, the Framingham study demonstrated there was a concomitant coronary artery disease reported in 70 to 80% of patients with peripheral arterial disease. And also the study of the autopsy study that was conducted in the military that died in Vietnam identified plaques in both the carotid and the coronary arteries and the aorta by the age of 50. Now, what is the magnitude of the problem? The magnitude is significant. I mean, in Europe, as a population that is half of that of India, but you can see that, and then you can make your calculations. So you see that in Europe, with 500 million inhabitants, there are 17 million patients with peripheral arterial disease. Now, if you believe that there are differences in the occurrence, as I showed you, in peripheral arterial disease, it is possible that in India you have something around 40 to 45 million of patients with carotid and peripheral arterial disease. But why it is important to identify polyvascular disease? You see that the number of locations of atherosclerosis, it correlates with cardiovascular death, non-fatal MI, non-fatal stroke, and with a composite of death, stroke, or hospitalization. These are data that were also replicated in a European study, where there was, you see that if there is multi-site atherosclerosis, vascular death, MI and stroke and death and hospitalizations are significantly higher. And if you look at the meta-analysis of all studies that looked at the presence of peripheral arterial disease and multi-site arterial disease, you can see that clearly there's this twofold increase in the occurrence of mortality and events in patients with symptomatic peripheral arterial disease, but also an increase of 80% in those patients who are asymptomatic. Now, what about the cardiovascular risk in peripheral arterial disease and coronary artery disease? These are data from the Fourier study, where they looked at the effect of PCSK9 inhibitors in patients with and without peripheral arterial disease. You see that in patients with coronary artery disease, I just suggest you to look at the data for placebo, in the presence of peripheral arterial disease increases significantly. It doubled by more than 50% the event rate. So it goes from 12.7% to 16.8%, whilst the effects of lipid-lowering therapy remains the same. So in patients with cardiovascular risk and peripheral arterial disease, then it is important that to understand that there is an increased risk. So why do we need to screen, and do we always need to screen for multi-site arterial disease? Now, the systematic screening for multi-site arterial disease is not indicated for all the presentations of peripheral disease, and especially when there is a need for an urgent revascularization. However, there is a clear indication for the screening, for opportunistic screening for multi-site arterial disease in specific patients. And this is the group of patients with increased cardiovascular risk before elective coronary artery bypass grafting, before coronary revascularization, and in patients with non-flow limiting coronary artery disease. So it is important that whenever you see these patients, you always think at conducting and the screening for multi-site arterial disease, but also there is a clear recommendation that is a 2A recommendation, that in patients with coronary artery disease, there's a need for screening for abdominal aortic aneurysm, and I will go back into that later in my presentation. Now, as I showed you, the risk for the cardiovascular risk in patients with increased risk, or patients with risk factors, or patients with established coronary artery disease is not a one on-off. It's just a graduation of risk that starts from low risk, patients with multiple risk factors, then they have subclinical atherosclerosis, and then the risk increases in those patients who have an event. And we can assess the risk of patients with cardiovascular disease, with risk factors, by using the score chart. This is a chart that has been developed by the European Society of Cardiology, and that is a correcting factor for all the different populations worldwide. Now, for what is important is that the classification of very high risk in the score charts is also basically demonstrates that they're not just patients with a previous cardiovascular event who are at very high risk, nor all those with the PCI or coronary artery bypass graft, but patients with the presence of a significant plaque on coronary angiography or CT scan or on carotid ultrasound are to be defined as patients at very high risk. So you understand that if we go here and we find a patient with low risk, say green, and then we do an opportunistic screening and we find a carotid with a carotid ultrasound, the presence of plaque, that patient goes from green to dark red, so from very low risk to very high risk. And also the recommendations for cardiovascular imaging for the assessment of cardiovascular disease, according to the European Society of Atherosclerosis and the European Society of Cardiology, there is a clear indication for arterial plaque burden on ultrasonography as to be considered in all individuals at low and moderate risk. And why? The reason is that assessing and defining the risk basically gives you a very good indication on how we need to intervene in that patient. So whether we have to use only lifestyle modification, whether we need to use a drug, or whether we should start straight from drug. So we know that for LDL cholesterol, we have different targets. So in patients who are at low risk, we can we should achieve a 3 millimoles per liter of LDL cholesterol. In those with moderate risk, 2.6. In those with high risk, should be below 1.8. And in those with very high risk, 1.4. Now, you can very well understand that if we assess our risk in a subject that is here, then of course we will aim for an LDL reduction down to 2.6 millimoles per liter. But then if we identify a plaque in this subject, and that subject becomes at very high risk, you see that immediately we have to change our strategy and our target. Rather than 2.6 millimoles per liter, becomes 1.4 millimoles per liter. So you see the importance of identifying the peripheral arterial vascular disease in order to redefine the target for lipid lowering therapy. So if we go here, we have this lady with a total cholesterol of 5, that is a non-smoker with a blood pressure of 140. So she's just borderline. And then we perform a vascular ultrasound and we find plaque. Then you see that that lady gets a risk that is the similar of a lady of a similar age with a blood pressure of 180 and with total cholesterol of 7. So you see that how it is important to use the vascular ultrasound to redefine the risk of our patients where we believe then the risk is very, very low. Now, we know that once we identify the risk, it is important that we can reduce that risk. And dyslipidemia is the major and the most important modifiable cardiovascular risk factor in our patients, together with inflammation, sedentary lifestyle, and diabetes. But no matter what the other disease or comorbidities are present, it is our key is to reduce LDL cholesterol, because by reducing LDL cholesterol, we can significantly reduce the risk of future events. And this is important also in patients with diabetes. These are data from the UK-PDS study. The UK-PDS study was a study in patients with diabetes where they looked at strict or lenient glucose control. And what they found was that in diabetic patients, the LDL cholesterol is even more important than glycated hemoglobin or blood pressure. So that tells you that we need always to aim for the LDL, target LDL cholesterol. And all studies, all intervention studies with lipid-lowering therapies have clearly demonstrated that the lower the cholesterol, the lower the progression of atherosclerosis. And there is a turning point. There is around 80 milligrams per deciliter of LDL cholesterol, so 1.8 millimoles per liter, below which we can even achieve a remodeling of the atherosclerotic plaque. Now, all studies with LDL reducing agents have clearly demonstrated that LDL reduction reduces cardiovascular events and major cardiovascular events, and that this reduction in events is linear, and it is function of the total and overall reduction in LDL cholesterol, but also on the level or the achieved level of LDL cholesterol. Now, we know that whenever we look at trials, we look at this difference here. And this is the difference between a treatment and placebo. But we always forget to look at here. So what is the residual risk of that patient? Because it is okay that if with a statin, we reduce that risk by 22%, but that patient is left, these patients are still left with a significant 8.7 absolute risk of disease. And these are data that were obtained by with atorvastatin in the study that assessed the intensive atorvastatin LDL reduction, or those with a more lenient. But no matter what, we tend to be inefficient in reducing LDL cholesterol. And you can see that the LDL cholesterol goals are infrequently achieved in high-risk patients. And this is consistent. And if we look at all the observational studies, you see that the percentage of non-achievement of the goals is around 80%. Of course, there are variation between cardiology and other specialties, and because cardiology specialists tend to be more aggressive. But despite that, there is still a large proportion of patients where we need to be more proactive, because there are different reasons why we don't achieve these LDL levels. Part of that are related to patients. So we have patients who cannot tolerate the optimal therapy because of muscle pains, increasing liver enzymes and CK, or genetic variability in response. We sometimes even see with the PCSK9 inhibitors that the LDL cholesterol is not reduced as much as we were expecting. But also there are patient-related factors. There are countries like, for example, India, where there are difficulties in order to access the optimal therapy, where there are difficulties for paying drugs that in other countries are extremely cheap and for the economic standards. So there's the issue of access to treatment, patient-related response, but also physician inertia. But it is important to understand that if we stop starting therapy, then we expose our patients to an increased risk. And you see that this study was, in this study, they looked at the effect of statin withdrawal in patients with who were on statin, and you can see that leads the statin withdrawal increased by 38% the risk of future MI. And in patients in primary prevention, there is an increase in 26% in myocardial infarction, 18% in cardiovascular. Now, given that there are factors related to tolerance to medications, then a new step forward, a leap forward, has been made with the PCSK9 inhibitors. I believe all of you know very well how the PCSK9 work. Basically, the PCSK9 binds to the LDL receptor that is internalized and then gets metabolized. And the inhibitors, that by blocking the PCSK9, they inhibit the binding between PCSK9 and the receptor, and therefore the receptors binds the LDL, brings the LDL into the cell, and then can be recycled up to the surface in order to, and therefore there will be more LDL receptors available for the LDL and receptor interaction, and therefore internalization. Now, the PCSK9 inhibitors have clearly demonstrated a significant reduction in events in patients with cardiovascular disease, and this is a reduction around 60%. You can see that in the GLACO study, they've looked at the correlation between the change in LDL cholesterol and the change in atheroma, finding that the more you reduce the LDL, the greater the reduction of the LDL, the greater the reduction of atheroma. And also, there's clear evidence that the PCSK9 inhibitor, they have a significant effect on reducing events over time, with a relative risk reduction after the first year of 25%. So it is important to identify patients with increased risk, because if we identify the increased risk in patients with moderate or low cardiovascular risk, and then we can reclassify them to higher risk, and therefore starting lipid lowering therapy. But also, peripheral arterial disease is important in patients with, say, heart failure with other conditions, other cardiovascular conditions. Because if you look at patients with heart failure, you see that those patients who had peripheral arterial disease and heart failure, or peripheral arterial disease and LV dysfunction, had a significantly greater occurrence of future events compared to those patients without peripheral arterial disease. And also, if we look at the NT-proBNP, those patients with worse coronary heart failure, they tend to have, and therefore that they have a higher NT-proBNP, they tend to have more peripheral arterial disease. And that is important also because it builds up to the symptomatic effect and in the deconditioning of patients with heart failure. So even in patients with heart failure, especially in those patients with heart failure with an ischemic origin, is important to screen for peripheral arterial disease. Specific point is for patients with atrial fibrillation, because peripheral arterial disease is frequently associated with atrial fibrillation, but it's not just that. I mean, there are data from the cardiovascular health study that demonstrated that lead was associated with an increased risk of atrial fibrillation. And therefore, if we identify a patient with, or we have a patient with palpitation, where we identify and increase the presence of peripheral plaques, then we can clearly see that that patient is at increased risk of atrial fibrillation, and therefore treat them more appropriately in order to prevent the paroxysmal atrial fibrillation. But also what is important is that the peripheral arterial disease modifies the Charts-VAS score, and we will discuss that later on how it is important to assess clearly the Charts-VAS score in patients with atrial fibrillation, and therefore a specific role of a vascular ultrasound in patients with atrial fibrillation and say low Charts-VAS score, where we need to better define the need for NOAC treatment, is very much needed. So we know that, for example, whenever we have a patient with atrial fibrillation, we need to start them on NOACs only if the Charts-VAS score is greater than 1. Now, of course, vascular disease, they give you already 1 point. Therefore, if we have those patients with 0 or with 1, where there is a very gray area for the indication of NOAC therapy, the identification of a carotid plaque or an aortic aneurysm or the presence of lead may reclassify those patients and therefore give an indication for new oral anticoagulant. So in conclusion, atherosclerosis is a multi-site disease that should be assessed holistically. So there's no point of thinking that the disease can be just at the coronary level, or the carotid, or at the abdomen of the peripheral arteries. And it is important also to realize that patients with where we identify the presence of peripheral plaques on the carotid, at the level of the aorta, or the iliac artery and femoral artery, they are at a significantly higher risk of future cardiovascular events. The detection of peripheral arterial disease is a risk modifier in primary and secondary prevention, and therefore influences patient management. And we know that today, if we re-stratify our patients with multiple risk factors, then we can clearly start new therapies that are very safe and effective, but also we classified those patients being at a higher risk. That leads to a different target for starting therapy. Now, peripheral arterial disease and coronary artery disease often coexist in up to 70% of patients with peripheral vascular disease have coronary artery disease, and patients with peripheral arterial disease have very high risk and therefore should be treated more aggressively. And I showed you the results of the effect of PCSK9 inhibitors and statins, and the compelling need to be very aggressive in these patients. Therefore, in patients with coronary artery disease, atrial fibrillation, heart failure, the screening for peripheral arterial or carotid atherosclerosis or peripheral atherosclerosis identifies patients at higher risk and those that need a more intensive lipid-lowering therapy. And this is the reason why we should always be pursuing the vascular ultrasound in patients at increased cardiovascular risk, patients with low to moderate risk, but also in patients with atrial fibrillation, and in patients with heart failure, and in those with coronary artery disease. I will stop here and be happy to take questions.
Thank you so much, sir. Sir, can we have the question and answer after Dr. Vitali's session, sir? Because
Okay.
we now have a small, any clinical cases that Dr. Vitali you would want to share?
Perfect. Yeah,
Yes, ma'am.
absolutely.
Yes.
Thank you so much. I would go very probably quickly, so maybe we'll give more time for the questions and eventually we can go back at the end with another case. So this is a woman presenting to the doctor because due to an increase of the level of blood pressure occurred in the last 3 weeks. If we look at the risk factors, she is an ex-smoker. She had an early menopause, very early, 44 years old. She's overweight, no physical activity, and she has an history of mild hypercholesterolemia. So if we look at the value of the pressure, of course, taken and control at home, of course, we should monitor blood pressure, eventually ask for an BPM examination, but we can say that probably this patient is developing or has a grade 1 hypertension. Nothing to highlight at the physical examination or the ECG or the echocardiogram is important. She has no LVH. She has a cholesterol level of total cholesterol of 200 and non-HDL level of cholesterol of 137. So what the guidelines suggest us, they suggest in this patient with grade 1 hypertension to assess the cardiovascular risk. And this is a very similar case of the one that Professor Rosano mentioned. And for this, I would say I'll try to go quickly. This patient has a very, I would say, a low risk. And if we look at the general assessment, we can say she has probably 1 or 2 risk factors because the level of cholesterol, everything I would say is quite borderline. So we can say she's at low or moderate risk. And if we look at the score according the guidelines of dyslipidemia, in this patient, we should advise lifestyle, of course, modification, but we should probably think if prescribed or not a medication only after a period of lifestyle changes. So I try to identify 2 different scenarios. The first scenario is Dr. 1 decided it's okay, this patient has grade 1 hypertension. It's true, she's overweight, she has borderline level of cholesterol, but I think we can try with lifestyle advice and prescribe blood pressure treatment. So maybe I can ask Professor Rosano what kind of treatment he would suggest for this patient.
I would say that whenever we suggest lifestyle modifications, the lifestyle modifications, they work for a very brief period of time. We have patients that they may start on a diet, they will start the diet, then they will stop it the following Monday, or maybe they will stop after 3 or 6 months. So if we have a patient that is youngish, then we should and more starting therapy, and for sure we in this case we should start immediately with the treatment of blood pressure.
Perfect is what has been done, but at the same time we have another approach. So no, it's not me, I promise, is if we think better maybe at this patient and we want to investigate better, even according to what we said today about the role of subclinical atherosclerosis. If we think at this patient, she told us she feel blue, so this mentioned probably she's sad, some symptoms of depression. This is non-traditional risk factor. I mentioned already the early menopause, to be overweight, no activity, so, and the hypercholesterolemia not in treatment. So we have few different elements that maybe we should take into consideration. And we said that already we have performed ECG, echocardiography, but we decide maybe to perform a carotid ultrasound. I would say we can perform even an ankle brachial index, but this is a young patient, so maybe we do not find anything at this evaluation. As you can see, this is a carotid artery, is a bifurcation, and as you can see at the level of the anterior wall, we have this quite big plaque that I would describe as a dishomogeneous plaque with some calcification, and we have even this small plaque at the level of the posterior wall. As I mentioned earlier, we are probably not so interested in this patient because it's an asymptomatic patient in understand how big is the plaque, but of course we'll do in our assessment. And as you can see, we have two different percentages of stenosis. This is due to the different methods that have been used. We have this method is the NASCET, according to the NASCET, that evaluate the diameter, the residual the diameter in compared to the vessel, the diameter at the distal carotid artery. This is the ECAST method that measures the size of the plaque at the level of the stenosis. We know that this method, the ECAST method, usually overestimate the plaques, and you see that we have chart that help us to better understand the real size of the plaque, even though the element that tell us how big is the plaque is always the hemodynamic method. In this case, we have a velocity of roughly 60 centimeters. So this means that the plaque is less than 50%. And this is what we are interested in. But as I said earlier, probably we are not interested. We are interested that is not an hemodynamic plaque. So this means we do not need to treat this plaque surgically, but this plaque increases the risk of these patients. And not only at the level of the carotid arteries, as you can see, even at the level of the femoral arteries, she has already the presence of disease. So as Professor Rosano mentioned earlier, this patient moved quickly from low moderate risk to a very high risk. So I can ask Professor Rosano now, do you think this patient should be advised to take statins?
Absolutely. I mean, and there is a very simple reason. I mean, this patient is a very high risk. So no matter what diet, then we won't expect with diet, even with a stricter diet, to get more than 20 to 30% reduction in LDL cholesterol. While here, we should aim for a target of 50 milligrams per deciliter. So that means that we will never achieve the target level without statins.
Perfect. And I would say I think all of us agree what Professor Rosano just said. And another question, maybe quite interesting, can be, do you think this patient should take a single or dual antiplatelet therapy or not?
I don't think there's any clear indication for using antiplatelet therapy. I think that if you're aggressive with lipid lowering therapies, as I showed you earlier, it's not important what is the degree of stenosis, but how the plaque looks like. And I showed you also the fact that with the statins and PCSK9 inhibitors, you tend to stabilize the plaque, and therefore it's better to be aggressive with statins and less aggressive with antiplatelet drugs. Also, because in women, the benefit of aspirin therapy is questionable because there is an increased risk of bleeding that is not offset by a significant reduction in the risk of stroke. And that is in keeping. I see here the recommendations, and you can see that the ESVS has downgraded from 1A to 2C the use of antiplatelet drugs, while there is a clear indication for the use of statins.
Perfect. Thank you so much. I think we have done with this case.
Thank you so much, Dr. Vitali ma'am. Just to say this, actually, uh, as the case was moving on, we actually have feedback from 8 clinicians live who have just written to us. What a wonderful case, and the conglomeration of the case, as well as the utility, be it the medications, be it understanding risk factors, be it understanding the role of vascular ultrasound. Phenomenal, fantastic, ma'am. Thank you so much.
Thank you so much.
Professor Rosano and
Yes.
Vitali ma'am and Dr. Fabrizio, we just have a couple of audience questions which we would like you to take. So the first question goes to Dr. Vitali. Dr. Pednekar asks, in interventional cardiology procedures, when should intravascular ultrasound be performed? Is it more from the perspective of a lesion morphology, or to quantify a plaque burden, or for guiding the stent? The reason, sir, the reason Dr. Pednekar asks is because intravascular ultrasound has not yet percolated too much into India. Overall vascular ultrasound has, but intravascular ultrasound has not yet percolated very well, and the cost of doing the same is high. Your take on the same.
Yeah, exactly. Is I would say what we tend to do is use something non-invasive that can give us an easy access. So, of course, the level of the information that we want to acquire is different. Of course, intravascular ultrasound has been performed at the level of the coronary arteries, of course, give us lots of information. But as I said, I think the real value of vascular and peripheral ultrasound is just that it is accessible. It's something very easy for our patient, is repeatable, is not invasive. So I think the key is this one. Of course, we will have less information. Of course, other techniques, MRI, CTA scan will give more information about morphology. But what about the costs? Higher costs, radiation. So I think we should start at the first level. We start using, and is like the physical examination. So is we build the assessment of our patient, but we should start from something simple and easy, in particular if give us very important information.
Yeah, and if I follow that, and especially probably they were also interested in the intravascular ultrasound. For the intravascular ultrasound, I think that there is a specific place when you have doubt about the apposition of a stent, not as a routine, because it's a lengthy procedure and it's costly. So if you are worried about the plaque, then probably the OCT, it's better because it tells you whether that plaque is unstable. But the intracoronary ultrasound, it's costly and it doesn't add too much. Now, today we're moving towards the FFR, measurement of FFR, and that is probably better. But there are specific cases where there is a compelling use for the intravascular ultrasound. That is where we have doubts about the perfect apposition or whether we have covered completely a plaque that we don't like it too much. So it's keeping into account that the less metal we put, the better it is.
Thank you, sir. So the next question is to Professor Rosano. Sir, we Indians tend to have a very high incidence of polyvascular disease. We tend to have clustering of CV risk factors, a huge burden of diabetes, just second to the Chinese, high incidence of hypertension, visceral obesity. So phenotypically, we might look lean, but actually we are obese within. We tend to have a lot of atherogenic dyslipidemia with not just a high LDL, but actually even a reduced HDL and an increased TGL. So, your take also, and at the same end, there are also cost considerations when it comes to lipid-lowering therapy. For example, PCSK9 inhibitors are not very accessible to Indian patients. So, post the clear outcome study, which was with bempedoic acid, so your take on maybe statins, high-intensity statins first, followed by ezetimibe, followed by bempedoic acid. How does this sound in a resource crunch scenario? Your takes.
No, I mean, we've seen, and it was just published in JAMA, 2 days ago the results of the bempedoic acid showing a clear benefit in patients who are statin intolerant. So there is a clear space for bempedoic acid, although that is clearly not very cheap. It's not. I mean, it's not as expensive, but it's that is a specific place, and especially when we identify with what Dr. Vitali just showed us, that patient is at a very high risk, where there's a need to be very aggressive with lipid-lowering therapies. Now, you've also touched upon the importance of the non-HDL cholesterol, so the triglycerides, the abdominal obesity, and for these patients, I mean, it's if we achieve a certain reduction of LDL cholesterol, but the non-HDL cholesterol is still high, and triglycerides are high, then there is a space for the use of fenofibrate. And we have data from the FIELD study and from the ACCORD study, where specifically patients with atherogenic dyslipidemia, so there were those with a non-HDL greater than 110, had a significant benefit in reduction in events. And for example, often we discuss about patients with diabetes. And in patients with diabetes, the diabetologists advocate the strict glycemic control for the reduction of peripheral vascular disease and amputations. But with fenofibrate, you have a 30% reduction in need for eye surgery for microvascular dysfunction, and also 30% reduction in amputation. So I think we have to take an holistic approach, and especially where we have to look at costs. We cannot always pursue the PCSK9 inhibitors. I mean, there's a stepwise approach, but always with statin. Then if that is a patient with a profile where the triglycerides are lower or within the normal limits, then pursue the reduction, the further reduction with bempedoic acid, either in association or for the patients who are with statin, and ezetimibe. But in those patients where the non-HDL cholesterol is high and the triglycerides are high, you can use the fenofibrate, and fenofibrate can be used in association with statins, unlike other lipid-lowering medications.
Thank you so much, sir, for the same. The next question is to Dr. Fabrizio. Dr. Fabrizio, Dr. Kunal asks that during his early training days, he used to use a fast ultrasound for understanding IVC collapsibility also in shock. So on the same note, he asks you, can vascular ultrasound actually be used in the ER to detect cases of an aortic dissection, where ideally the patient is sent for a CT? Your take on this?
Thanks for the question. Aortic dissection is quite difficult to detect with ultrasound, but it can be detected. You can see dissection at the level of the abdominal aorta, and if the dissection is acute, it will look like a very subtle line flapping within the abdominal aorta. If you do a transthoracic echocardiography, you can detect dissection even at the level of the aortic arch, at the level of the proximal region of the descending aorta. It is not the most accurate method. However, we do see dissections with ultrasound, and when you see them, you take immediate action. So I wouldn't say it's the best method, but in expert hands, you can detect acute dissections.
Thank you. Thank you, Dr. Fabrizio. The next question to Professor Rosano and Vitali, ma'am. Your experience with inclisiran, it is not yet available to Indian physicians. Your experience with inclisiran, and what are the patient populations who should be given this? Professor Rosano.
Inclisiran has just started to be on the market in the UK. Started in Italy, and the results are similar to those that you achieve with the PCSK9 inhibitors. Of course, in terms of degree of LDL reduction, of course, the mechanisms is different because it's an interferent RNA, and therefore has an effect that is longer lasting. And but I think that there are patients where, and I didn't have time to show with where we have a PCSK9 inhibitors are not effective, and or less effective than we think. Then in these patients, the interferent mRNA with the inclisiran is effective. I think it's too early to discuss about the experience, because we even in Europe, although it's in the market, we are in the early ages, and we cannot really compare between one and the other.
Thank you, sir.
Yeah, I definitely agree. The experience is too early to say something. I think even the experience with PCSK9 and the plaques at the level, of course, we know clearly the effect. We are learning, it's a learning progress. So we have just now some data, even at the level of the carotid arteries. Of course, we have clear data at the level of the coronary arteries, but still quite new from some aspects.
Once again, the last question of the day to both Professor Rossano as well as Dr. Vitali ma'am. From the same perspective, as we discuss lipids, again, the same concept of polyvascular disease, multivessel disease in the Indian scenario. Your take on the role of low-dose rivaroxaban with aspirin for coronary artery disease and peripheral arterial disease. Your key messages to Indian clinicians. Yes, sir, and ma'am.
Yeah, I mean, there is a small increased benefit that where you pay in part with an increased risk in bleeding. So it's I think it's something that you should balance. And if the bleeding risk is low and is acceptable, so you need to always assess the Hasbled score. Something that in coronary artery disease and in vascular disease we don't do, because we're used for the Hasbled in AF, but not in vascular disease. So if the risk, the vascular risk, and it's a little bit higher, then the benefit probably is not there. In the Hasbled risk, low to moderate, there is a clear benefit, but again, there are issues with costs. And if there are issues, I think one important message is that if there are issues with costs, the cost will affect the adherence to treatment, because sooner or later patients will struggle to buy that drug. And therefore, it's better to keep them on a strategy that is effective and adherent long-term, rather than something that may be optimal, but then is discontinued. So that is my approach.
Yeah, I definitely agree. And we have to take into consideration all the risk factors of the patient, the multi-medication. So I would say go for what we know for sure, and maybe just some selective case when maybe the morphology of the plaques even can be at risk. But I would say statins. Our target is statins, cholesterol, PCSK9, and we know that they are effective. So this is the first approach, I would say.
Thank you so much, ma'am. We have reached the end of our audience Q&A, and we've had a fantastic session with the audience very clearly. We have had such an engaging audience, and the feedback is numerous. Even as we speak and as the Q&A has come, the feedback from the audience is, oh, wow, what a session. We might even want a version 2.0 is what the audience is actually requesting. So
I just have one video I wanted to show you as a part of my presentation, as the clinical case. We didn't do it. I mean, if you do allow me, it takes less than 1 minute. And I think it's important because it can add something else, a different perspective compared to what we said so far. So I won't go through the case. That is a case of patient with atrial fibrillation where there was an issue on whether we should start an anticoagulation. This was a patient with a Chard's mask 0, but then so there was no indication for anticoagulant. But then we did the echocardiogram that was absolutely normal, and at the end we did the screening for the aortic aneurysm. This is something I want to show you how easy it is to be performed. because it's you can basically start from the 4-chamber view, and after you've finished with the assessment of your patient, then once you've finished your transthoracic echocardiogram, you turn your patient lying flat, you identify the IVC, and something that we do usually for heart failure patients. Then we rotate the transducer by 90 degrees with the marker towards you, and then we can see the inferior vena cava and the abdominal aorta. So you see already with the 3.5 megahertz transducer, we can see the abdominal aorta, that it lies above the vertebral body, and also we can put the collar in order to find and identify the pulsatile flow, and then we can scan down to the aorta in order to identify the site where there is the largest diameter of the aorta. So this is very important, because then you place the caliper, and then you can measure the size, the aortic size. And this is something, I mean, you can also identify the aorta from the apical 2 chambers. But this is a message that the opportunistic screening should be always pursued, also in patients in order to assess the abdominal aorta whenever we do a 4-chamber, when we do a standard echocardiogram. And in this case, where the CHA2DS2-VASc score was 0, and this is what it was found an aortic aneurysm, and therefore that patient became high risk, and basically changed completely the approach. So this is maybe something is meat for the next meeting, where we can focus more on the abdominal aorta. But I just wanted to show you, because we had built this case, and we wanted to show how easy it is to image the abdominal aorta by after an echocardiogram.
Thank you so much, sir, for the same. With your kind permission, I would like to give the final vote of thanks. It was an honor to host Professor Rosano, Dr. Vitali ma'am, and Dr. Fabrizio. The Indian audience who have attended the session have hugely benefited from the same, and we are very sure that the clinical pearls that you have suggested, with very clean, clear, crisp messages, is something that will ultimately translate to better patient outcomes here at the clinical practice of each and every clinician who has attended the same. Dear audience, we also thank each and every one of you for actually taking your valuable time on a Sunday to attend the session, but we are very sure the academic feast that was there would be worth your time and ultimately empower you clinicians to do better in your clinical practice. Last but not the least, we also thank our technology partners, Mr. Raghu from Club Class, for aiding us with this wonderful webinar and the very smooth streaming of the same. Thank you, one and all. Take care. Good day.
Thank
you
you.
very much.
Thank you so much.
Thank you, ma'am.